Hello, this is Katherine West, Infection Control Consultant, working for many years with EMS agencies. Welcome to another hosting of Let's Get It Straight podcast. And today we're going to be discussing Ebola. Why are we discussing Ebola? Hasn't that come and gone? Well, not exactly. And so I thought it might be a good idea to talk a little bit about the history, where we've been, and where we are today with the most current outbreaks. So let's get started. So this is still an issue. As I mentioned, we have two new outbreaks. One is once again in the Democratic Republic of Congo, and the last one that we had in the Democratic Republic of Congo came to an end in about July of 2020. But once again, we have cases. The first noted February 7th of this year. And our second outbreak, reported in February of this year, is in Guinea. Now, this is very significant because there hasn't been an outbreak in Guinea since the one from 2014 to 2016, and this is the largest that we have seen. So the index case for the beginning of the outbreak in Guinea was a nurse who had been seen by 3 different practitioners and misdiagnosed each time. She passed away, and persons who attended her funeral, that resulted in 6 cases. 5 are family members, and the 6th was one of the practitioners that she had visited and described her symptoms to. Of that group, 5 have died, 4 have a probable diagnosis, and 1 person has a confirmed diagnosis. So a little bit of a brief review on Ebola. First, a little bit of history. Ebola is not a new disease. It may be to some of you, but the very first outbreak was reported in the Democratic Republic of Congo back in 1976. It was in a community that was near the Ebola River, and that's where the name Ebola originated. That outbreak included 318 cases and 218 deaths, for a case fatality ratio of 88%, one of the most deadly outbreaks in history. The Ebola virus, EVD, I think we were well introduced to just a very short time ago. And what this virus looks like probably is embedded in our brains. We were seeing it on the news continuously. We don't know the origin of this virus, but we do know one of the main ways that this virus gets around, and that is the African fruit bat. It frequents pig farms where farmers are throwing out scraps, and this bat is also a food source for the people of West Africa. This animal is butchered, and if the animal has virus and they're butchering it and there's blood splatter, then that certainly is a mode for transmission. Some additional issues that affect transmission of this disease in a group is that many of the population have a real distrust of Western medical professionals. They still rely on their tribal healers. There's also a distrust of their government. And they have traditions that may seem very foreign to us, such as families bringing bodies into the home to wash them after death. They have no personal protective equipment, no running water, and no disinfection agents. So there's no way to do any type of exposure prevention or exposure follow-up. There is human-to-human transmission. We have seen that well established over the years and transmitted through contact with non-intact skin, mucous membranes with blood, through secretions or organs of infected persons. Also, contact with contaminated environments. Signs and symptoms, that was also beat into our brains, and rightfully so. A sudden onset of fever greater than 101.5, weakness, muscle pain, headaches, sore throat, and that would progress into profuse vomiting and diarrhea. Many patients had a rash, impaired liver and kidney function, and external or internal bleeding. Now, note the parenthesis, 10% of patients presented with internal or external bleeding. I think many of us were led to believe that this was pretty much all patients. Not so. Persons were to be considered infectious as long as virus is present. The incubation period, the time from exposure to onset of signs and symptoms, we learned was 2 to 21 days with an average of 7 days. We were asked to get travel histories, an important part of patient assessment. Now, getting travel histories should be a routine part of patient assessment. We're a very global society. To assess for signs and symptoms of this disease, to practice standard precautions, and to put a surgical mask on the patient, because this is droplet transmitted. With regard to testing, look at the progress. We now have a 2-minute finger stick test for Ebola. We are also to practice droplet precautions. That begins with source control. We're hearing that now about COVID-19 as well. Always, basic infection control is to contain at the source. That is putting a surgical mask on the patient. Second is ventilation. Use of your rear exhaust fan. You're hearing again about this with regard to COVID-19. And putting the heat or air conditioning on the non-recirculating cycle. For personal protection, for healthcare workers, specific guidelines were published by the World Health Organization and by the Centers for Disease Control. Specific ones for EMS. That we were to use droplet and contact precautions, avoid contact with contaminated surfaces, and because this is droplet, when within 3 feet of the patient, to don a cover gown, gloves, face shield or mask and goggles, and practice good hand washing. We were to avoid aerosol generating procedures. Well, if we look at EMS in today's world, the majority of you have relatively short transport times. And that was one of the factors that came into uh, stating, when at all possible, to avoid aerosol generating procedures. Now, open suctioning. It's an important point to clarify that EMS does not do open suctioning. You maintain a closed, filtered system. So intubation would be the primary way that one might be exposed if not using personal protective equipment. Environmental service cleaning, as I said, any registered hospital disinfectant. PPE would be face protection, surgical mask, gloves, and we don't need leg covers or shoe covers unless we're going to be wading through large amounts of vomitus and diarrhea. Well, what about cleaning for Ebola? This started out being way over the mark. You do not need any special cleaning solution for the Ebola virus, just like you don't need a special cleaning solution for HIV, hepatitis B, or COVID-19. These are enveloped viruses. So what does that mean? An envelope virus lands on a surface, and when it does that, the envelope, the outer area of the virus, opens up, and then the internal part of the virus is very susceptible to low-level disinfection agents. Studies have shown that the Ebola virus does not survive on surfaces in the absence of visible blood on a patient care environment. And Ebola-associated waste, medical waste. All we have to do is inactivate any bloody waste. And we can do that simply by adding some bleach to the red bag. If it is waste, if it is laundry, we will talk about that in just a second. But once it is inactivated, it does not pose a health risk. So we need not follow any special precautions for Ebola medical waste once we've inactivated it. As I mentioned, there's no special requirements for handling contaminated linens. They would just follow standard hospital protocols. So where are we now in dealing with the current outbreak of Ebola? Well, we set up treatment centers, regional treatment centers that have expertise and facilities that would handle the care of an Ebola patient. So what would happen is if we had suspect patients in the United States, they would be rerouted to airports near these facilities. So that would hopefully take away the opportunity for the average EMS service to be in contact with an Ebola patient. Patients suspect for Ebola or coming from countries where there is an Ebola outbreak would be transported by trained personnel that are linked to the designated treatment centers. On March the 2nd of this year, the Centers for Disease Control and the White House put out a notification to all airlines and aircraft operators that they're now required to collect and transmit passenger information to the United States government for the purposes of public health follow-up. The Department of Homeland Security is also directing operators of aircraft to funnel passengers who in the last 21 days traveled from or who were in the Democratic Republic of Congo or Guinea to one of the 6 U.S. airports where the United States government is focusing public health resources, all in a way to quickly identify and contain any possible traveler-related cases. In November of 2019, the Food and Drug Administration officially approved the Ebola vaccine as being 100% protective. It had previously been used in the last outbreak of Ebola as an emergency use authorization medication. Currently, over 250,000 persons have been vaccinated, and it only requires a single dose injection. The Advisory Committee on Immunization Practices, which is an independent body that makes recommendations to the CDC, has recommended that Ebola vaccine be offered to healthcare personnel who are at risk for occupational exposure, either because they respond to an outbreak at a federally designated treatment center or they work at a federally designated treatment center. We also have another vaccine that's been approved. This is one that is given to patients who have been diagnosed early in the early stages of Ebola infection. So if we can reach them within 3 to 5 days after they begin signs and symptoms, this 3-drug antibody cocktail can be administered. It's believed to be at least 90% effective, and it requires 2 doses being given 8 weeks apart. Globally, we now have a vaccine stockpile program. The United States, along with the World Health Organization, UNICEF, Red Cross, and Doctors Without Borders support this project, and it's funded by the Vaccine Alliance. The global stockpile is located in Switzerland, and currently over 6,890 doses of Ebola vaccine are available. How about a little perspective? When our first case of Ebola occurred here in the United States, there was a lot of fear, anxiety, way overdue on personal protective equipment beyond what was needed or recommended. So perspective would include the fact that EMS personnel who transported the first U.S. Ebola patient in Texas, and he was transported twice actually, and the crews were totally unaware of what his disease status was. And none of them acquired this disease. He presented with vomiting, diarrhea, fever. No one contracted his disease doing standard precautions. That's an important point to remember. And that brings this review to an end. I hope you've gotten some updated and helpful information, because this disease has not gone away. And hopefully we will work toward eradicating it in the not too distant future. Thank you. Hope to see you again at our next podcast. Let's get it straight.